Hello and welcome to ECCMID TV, here from the 28th ECCMID meeting in Madrid, Spain. My name is Christoph Specht. I'm a physician with a background in tropical medicine and I'm a senior medical correspondent for German TV. Now let's get started, and I'm really honored to introduce to you my first interview guest. This is Dr. David Eyre from the UK, from the Nuffield Department of Medicine of the University of Oxford. And you had a very interesting talk about Candida auris. But before we get into details, maybe you could just give us a short outline what kind of fungus that is and why the threat is so big.
Yes, so this is a new fungus that we've only really learnt about in the past 5 or 10 years or so, and it's emerged worldwide and it causes a problem in critically ill patients. And it's special for two reasons really. One, because it's resistant to many of the commonly used treatments for Candida, and secondly because it's been associated with really quite high mortality in previous studies.
Where has it been first detected? I mean, it's Japanese, isn't it?
So it
is said to be.
Yes, it was first detected in the ear canal of a Japanese patient, but actually, looking back at historic collections, it had existed in other places before that. The first actual case that we've got on record was from South Korea.
Yes, and you had a pretty large outbreak at an ICU unit at your university institution. Tell us a little bit more about that. When did this happen?
Yeah, so our experience of this first began in July of 2016. There was a national alert saying, you may not be aware about this organism, Candida auris. Can you go back and look and see how many cases you've had before? And so when we did that, we found we'd had 9 cases in our institution over the last year or so, and when we looked more carefully, 8 of them were actually from our neurosciences intensive care unit. And so this really prompted us to start a big infection control effort to try and get it under control, and also an intensive patient screening program and environmental sampling as well. And then over the next year or so, we really grappled with how to control this outbreak, and ended up over the whole period having around 70 cases.
70 cases, so 70 cases, all of them being infected?
So the vast majority of our patients were colonized. We had 7 patients who developed an invasive infection, mostly bloodstream infections or a post-neurosurgical meningitis in our unit.
Any fatals? And
we had 1 patient who died of the patients who had an invasive infection, but actually this was over 200 days after their last isolate, so
it's
we
hard
don't
to
think
tell
it was
them.
particularly attributable to the Candida auris.
And what did you do in this study, so to speak, and what was the main takeaway, so to speak?
Sure. So we introduced at the start of the outbreak a number of infection control measures around isolating patients and cleaning and staff awareness. But despite doing all these things, we kept getting new cases. And so we then started looking at the environment very carefully, did a couple of samples from a couple of sort of rounds of sampling from the environment, didn't find Candida auris in the air particularly or in the general environment. But then one of the nurses suggested testing temperature probes that we use to measure patients' temperature continuously that sit in the axilla. And the first time we put one of those on a plate, we got profuse growth of Candida auris, and so that made us go back and test all the other ones in current use, and actually 4 out of the 5 probes that were being used.
So that was the culprit.
Auris. And so we thought that was the culprit, but then we wanted to triangulate that more, so we did a case control study and were able to demonstrate that 86% of our cases had exposure to these temperature probes, compared to 34% of patients who were screened but always negative. And then we also did some genomic studies where we took the isolates from the temperature probes and compared those to the isolates from patients. And what we found was that they were really very, very close. There was sort of mixing of the two. And then the final bit of evidence that these temperature probes were responsible was when we took them away. We then had the outbreak coming to a close, and actually we've now not had any new cases for more than 5 months.
So you didn't have any cases. Is it an ongoing threat, or might reemergence, is that possible or likely?
So we think it's important to remain vigilant for it, and we've got some ongoing screening that we're doing in the unit. We know because it had persisted so effectively in our hospital environment, there is a risk of it coming back, but as we go further and further along, we're more and more confident that we actually have managed to eradicate it, but that's not to say it couldn't be reintroduced to our hospital again.
Very interesting work. All the best to you, and enjoy Madrid and the ECCMID, of course.
Yes.
Thank you very much
Thank you
for
very
having
much.
you.
Thank you.